Morning.
Morning.
My name is Charlie Harles, and I'm the president of the Fibrous Dysplasia Foundation. And this is our fifth conference that we've held for patients and families about the current state of treatment, diagnosis of fibrous dysplasia and Mc-Cune Albright Syndrome. We started the foundation exactly 10 years ago. In 2004, several of us were meeting at my house in Washington because there were several patients at NIH at that time in the fibrous dysplasia study, and we decided, well, let's just have a little get-together, get to know each other a little bit better. And one of the things that we did is that a lot of us got in the hot tub later that night that we have in our yard. And we started talking about, well, what we really need is a foundation to focus our efforts on dealing with fibrous dysplasia, especially as patients and parents and other caregivers. We've done several, I think, really significant things over the years. One of them being 5 years ago, we did an international meeting that we co-sponsored with the National Institutes of Health. And I think what's amazing about that is that we paid for about 2/3 of that conference. We raised enough money that we were able to fly in doctors from literally all over the world to come in and spend 2.5 days in Washington, or at Bethesda at the National Institutes of Health. And as a result of that meeting, we published a whole series of articles in what's called OrphaNet, which is an online medical journal. And it's probably the best written information that you can find on dealing with the fibrous dysplasia. And like I said, we've also had other meetings, and we participate in a wide variety of activities in Washington on behalf of folks like you. One quick question for y'all. How many of you have been to one of the Fibrous Dysplasia Foundation meetings before? It probably looks like at least half, maybe more than half. And so hopefully we'll have some new information for you. You'll be able to ask questions. You'll be able to bring up with these doctors what the status of your particular situation is. And we've tried to do the agenda so that there's a lot of time for you to talk to other people. And how many of you, other than our meetings, have ever had a chance to talk to somebody else with fibrous dysplasia or a family member? Probably very, very few of you. There aren't that many of us out there, if you will. So hopefully you'll take advantage of this time that we'll have together to see how different people handle different kinds of situations and problems that they come up with both in their medical treatment and in their day-to-day life. Now, as far as this meeting goes, we had not had a meeting in several years. I think we almost burned ourselves out with the international meeting. That was a lot to bite off for a small organization like ours. But I was talking to a couple of our members, in particular, Cindy Levin from New Jersey and Dan Levine from New Jersey, New York area. And Cindy in particular asked me, well, what stuff can I do to help the foundation? And she probably will regret her answer now, but she said, I said, well, you can help us put on a meeting in the New York, New Jersey area. We really have. We did have our first meeting actually in New York, thanks to one of our members. And I said, I think it's time we go back up to the New York, New Jersey area. And so she has just been absolutely wonderful in terms of taking this on and doing, I would say, the bulk of the work along with Dan to make this meeting possible. So I'd like Cindy to come down and join me for just a second. Where is she?
Right here.
Mm-hmm.
Right here.
Oh. So just a little token of our appreciation that you can. And Dan, I'll treat you to a beer.
I like flowers.
with that, we'll get started with our program here. I was given 5 minutes, and Cindy, I believe she asked another attorney to only speak for 5 minutes. I'm sticking to my limit. I'm at 9:21 now. But in any event, you've got copies of our agenda. You've got a lot of information that we'll be sharing with you, and so I hope that you will take advantage of these doctors who have come to join us here, taking their weekends and going to spend the day with us. And so with that, I'll turn the program over to Dr. Michael Collins, who is the clinical director of the
Skeletal Clinical Studies Unit.
There you go. Clinical Studies Unit at NIH, and he's been intimately involved in these studies, natural history studies, and other studies dealing with fibrous dysplasia and Mc-Cune Albright Syndrome for, I guess, more than 20 years now at NIH. But I'll turn it over to Mike, and we really appreciate everybody being here, and hope you'll get out of this meeting information that's going to be helpful to you and your family as you go back to your homes.
Anyway, so I wanted to thank Charlie for organizing this, Cindy, Dan Levine, Amanda Conradi over the years who's done so much, and thanks to NYU. I think it was Dr. Gail Shorty who was the one who really started this off for us, so we have her to thank, and Renita, of course. Of course, I want to thank all the doctors, everyone who's coming here on their own time and donating their time. We really, really appreciate that. The thing I wanted to remind people, so all of the doctors have been asked if they'd be willing to review individuals' x-rays and that sort of thing, and no one has said no, so by default, everyone has volunteered. And really, I mean, we like doing this, so don't be shy, come up, grab us. There's at least one person who wasn't sure what kind of doctor to talk to, so I think if you grab any one of us, that'll be okay. Not all of the doctors are going to be here all the time. For example, I know Dr. Francis Lee has to leave shortly, so if you want to grab him, do that early. I would suggest grabbing people early on and seeing when they're leaving and when they're going to be here. The schedule's really tight, so you're going to have to grab these people. You may have to go out during another room during one of the talks. We can use the Q&A time, we can use the lunch time. Yes?
So if I may say, we reserved some of the rooms upstairs on the second floor.
Okay.
And they're listed on the program during certain, for example, during the break. Rooms 202, 203, 204, 209, 210, 211, and 212 are available for our use today. But if you need to get up there because you're in a wheelchair, one of our staff can help you in a different direction. Otherwise, the stairs are right here. Okay?
And so please take advantage of this. We like doing this. And we have, 3 orthopedic surgeons, 2 craniofacial surgeons. We have several pain people. We have several endocrinologists, so there should be someone for everyone. Okay? And again, it's going to be a tight schedule, and we're going to try and get a lot of information in during these short talks, and I'm going to do my best to try and keep people on track, so if I hope I don't offend any of my colleagues if I, cut you off, but we have to stay on schedule. And in that regard, so in terms of questions, the questions are really important, but there's not going to be enough time to take questions with the talk. There are specified question and answer sessions on the schedule, so we'll do those questions and answers then. Okay? Alrighty. So with that. So this is the sort of original paper to which the relatively modern history of fibrous dysplasia and Mc-Cune Albright Syndrome is traced. This was the original paper that was published in New England Journal in 1937 by Fuller Albright. There had actually been a previous, earlier paper by Dr. Donovan Mc-Cune, so based on the work of these 2 gentlemen, this disease has acquired the name Mc-Cune Albright Syndrome. The word fibrous dysplasia evolved later. Initially, the bone disease was called osteitis fibrosa disseminata, so we should be quite glad that it had a much easier name given to it. And this was given to it by Louis Lichtenstein in 1937. He called it polyostotic fibrous dysplasia. And then in a paper later on, based on their observations, they made the speculation that this disease is caused by, and I love this sentence, caused by the perverted activity of the specific bone-forming mesenchyme. And they really were quite prophetic in that, and it was really a long time before it really became recognized. And this was really the work of Dr. Roby and Dr. Bianco, where they did, in fact, that this bone-forming mesenchyme, which has now, has a number of names, we'll call it the skeletal stem cell, it is really the cause of this disease. This is a disease of the skeletal stem cell, fibrous dysplasia. And so what is the skeletal stem cell? So the skeletal stem cell is a cell that resides in your bone marrow, and it's a cell that has the potential to make several tissues. It can make bone cells, it can make cartilage cells, it can make the fat cells that are in your bone marrow. It's a cell that's essential for the support of blood production in your bone marrow. And then so what happens, what goes wrong in fibrous dysplasia? Well, what goes wrong is that the ability of these stem-like cells to mature into these, what we call more differentiated cells, the bone cells, the cartilage cells, etc., that gets disturbed by the mutation that these cells bear. And that what happens, instead of these cells maturing into bone-forming cells, they proliferate, they multiply as these sort of immature bone cells like this. There always is some small number or some large number, depending, of normal cells within this. So you have a chunk of fibrous dysplasia, will be a whole bunch of these mutant cells that aren't able to make bone, they aren't able to make cartilage, they aren't able to do the job that they're supposed to do. But what appears to be the case, and Dr. Roby is going to talk about this more later, there are some normal cells within that. And what seems to happen is that with age, these abnormal cells sort of burn out. And this sort of fits with what we think, or what we usually observe with the disease, that the worst part of the disease seems to be in childhood. That's where there's the most fractures and the most problems. And to some extent, the disease sort of burns out with time. But again, Dr. Roby will talk more about this in more detail later. Okay, so what has come to be called Mc-Cune Albright Syndrome was originally defined by this triad of symptoms. The cafe au lait spots, the ones that you see here, very particular kinds of cafe au lait spots, often precocious puberty, and the bone disease that has become fibrous dysplasia. With time, it was recognized, though, that other aspects of this disease, other problems could be associated with this disease. There could be problems with the thyroid, problems with growth hormone secretion, a disease of the adrenal called Cushing's. There's problems with mineral metabolism, blood phosphorus can be abnormal, and there's others as well. So, and this becomes a problem, and this becomes an issue, and it's really just a semantic issue. Sometimes people wonder, well, do I have fibrous dysplasia, or do I have Mc-Cune Albright syndrome? What is it? And it really is a semantic issue. Any combination of these can occur. So we typically say that you have more than one of these things. So for example, if you have fibrous dysplasia and you have a cafe au lait spot, then we call it Mc-Cune Albright syndrome. But it's important, I think, not to get hung up on what the label is, because essentially the fibrous dysplasia, whether it's just fibrous dysplasia or fibrous dysplasia as part of the Mc-Cune Albright syndrome, is the same thing. And any of these can exist in any combination, and they do exist in any combination in any group of patients. And there's really a tremendous amount of variability in terms of number of tissues involved, which tissues are involved. This then is important because depending on the treatment for all of these people is going to be different. So you may talk to some people, or you may read on the website that, this person had this and they had this done, and well, why am I not having that done? Well, it could be that your disease is completely different from that person. The other thing that's really hard about this is because no two patients will be alike, is that it's really hard for doctors too. Your doctor may have seen one or two cases of this, and the first case could be completely different than the next and the third. So it's really very difficult. So it's a difficult disease, and that's why it's been so hard and taken so long to really begin to get a handle on how to understand and take care of patients with fibrous dysplasia. All right. So what causes FD? So FD is caused by a mutation in a gene The gene is called GNAS. The gene codes for a protein. The protein is called GS alpha. It's not important to remember these, but sometimes you'll see these floating around and you might wonder. How prevalent is the disease? We really don't know. We've sort of pulled these numbers out of the air. We know that it's rare. It's probably fibrous dysplasia by itself is not so rare. The complete constellation of Mc-Cune Albright Syndrome is quite rare. So start probably somewhere in this range. There's no known cause for this mutation. The mutation did not come from either parent, and nor will the mutation in the gene be passed on to any of the children. This is very important. GS alpha, this protein that is expressed for all practical purposes in every tissue in the body. So really, every tissue in the body is fair game for problems with this. And this will give you a sense of the complexity of this disease. And it acts in some ways. One way to think of it is as sort of an on and off switch. So if it's in a skin cell, it turns on melanin production, and that's how you get the pigment. If it's in the ovary, it turns on estrogen production, and that's how you get precocious puberty, etc. So fibrous dysplasia in the bone, hyperthyroidism, and if it's in the pituitary, growth hormone excess. So it's sort of a master switch in many cells that it functions in. It does other things in the pancreas, in the brain, etc. Okay. So how does this happen? And this is our sort of working hypothesis of how this occurs. We think that a mutation occurs in a single cell by chance very early in development. Remember, it has to be in a skeletal stem cell, so it has to be in a very, very early cell. This mutation occurs by chance. As the organism, as the embryo develops, this single cell that had this mutation now involves what we call all three germ layers of the developing embryo. And this will give rise to what we see later. So these mutated cells here will then migrate out to various parts of the embryo. And again, tremendous variability. In one patient, it might be part of the bone, and another patient could be the entire skeleton. And they might not have endocrine problems, they might have endocrine problems. But somewhere, somehow, these cells migrate out here, and then as the organism develops, and as the person develops, this is really what determines the final appearance, the phenotype, we call it. And in this particular person, for example, we see that he has fibrous dysplasia in his skull, that his thyroid is involved, and his left femur is involved, but his right one isn't. And so this is how we think this works. This is sort of the working hypothesis. The implications of this are really, really important. So what I'm showing here then are the various aspects of the disease. And this sort of shaded area here, we know then that this map of the disease is established very, very early, in utero. But the map may not become apparent, you may not be able to read the map, you won't have symptoms until certain ages. So if, for example, fibrous dysplasia, we take that, and probably most patients, if we look very carefully, we can see it by the age of 5. And the overall implication of this, though, is that by the age of 5, for the most part, if we look very carefully, we can find all aspects of the disease. So the important thing here is that from a very early age, you can know what you're dealing with. We also know that, for example, very early on, if you don't have this, that, or the other thing, you won't get this, that, or the other thing. So this can give you some comfort to know, for example, if the right side of your skeleton isn't involved by the age of 5 or 10, the right side of your skeleton will never be involved. If the thyroid is not involved by the age of 5 or 10, the thyroid will never be involved. So if you look very carefully by specific testing, which the different doctors will go over in their talks, to look for example, if there's thyroid involvement or growth hormone involvement, you can determine very early on whether that's going to be an issue for you or your child. So I think this is a really important point. Okay? All right. So why the GNS gene? Well, for certain complicated reasons, it's a gene that is sort of prone to have mistakes occurring. And if this mistake occurs just at the wrong spot or the right spot, this is what happens. So it really happens by chance. There's no known environmental, ethnic, or geographic risk factors for the development of this disease. It's always the mothers who ask what it was they did during pregnancy, and it was nothing. Fathers never ask. I'm not sure why that is. But it was, in fact, I had one woman, she was a Chinese woman, and her son had Mc-Cune Albright Syndrome, and when she had been pregnant with him, part of the lure was that if she ate pearl dust, it would give him a lighter pigmented skin. So during her pregnancy, she ate pearl dust. And she carried this with us her entire life, that it was her eating that pearl dust that did this to her. And this really was a burden for her. This really caused her tremendous pain. So it was interesting. I don't know that I was ever to convince her that it wasn't that, but it wasn't anything you did. So far as we know, all of the cases are sporadic, and again, this makes the point that the parents didn't, per se, give it to the children, and the patients with the disease won't pass it on to their children. All right. Something that comes up a lot of times is how do you diagnose fibrous dysplasia and Mc-Cune Albright Syndrome? And it's not simple sometimes. There's not a blood test where you can send the blood test and you check it, oh, you have it, oh, you don't. And so it's really a lot of times, your sort of best guess. So if, for example, you have a typical X-ray and you have these typical pathologic spots and you have precocious puberty, well, it's absolutely certain. You don't need to do anything more. You don't need to do any gene testing. The diagnosis is very clear. But if you go down this list of spectrums here, if the disease is in an atypical location and the X-ray doesn't quite look right and there's no skin problems or no endocrine problems, there's no biopsy, there's no mutation testing, it really can be quite confusing. I think Dr. Burke may talk about this. The one area in particular where there's a lot of confusion is in the bones of the skull. There's a lot of skull bone diseases that can look like fibrous dysplasia but aren't fibrous dysplasia. So the gene testing can help, but it's not perfect. I think a lot of doctors especially are hung up on the fact that we have to do the gene testing. Gene testing is not perfect for any disease, and especially not for this one. The biopsy, if you have a typical biopsy, a lot of times we think that if you do the biopsy, that's the gold standard, you'll have the answer. Bone pathology is a tricky business, and I think there's probably a handful of bone pathologists in the world who you can really trust to make this diagnosis. So just because there's been a biopsy doesn't necessarily mean that it's absolutely clear either. So it can be tricky, and not infrequently mistakes are made. Okay. These are the bones in the skeleton of fibrous dysplasia that are most commonly involved, and you'll hear more about this later. Again, the skull and the skull base is the area that's most commonly involved. After that, the femur and the pelvis, and then other bones after that. So as to when and where the fibrous dysplasia appears, we know that by looking back at all the patients that we've seen over the years that 90% of the disease of fibrous dysplasia that a patient will ever get in regard to the craniofacial disease is established by 3.4 years of age. The fibrous dysplasia in the skull is most readily apparent very early on. In the extremities, most of the disease is present by the age of 14, and the axial skeleton by the age of 15. So almost all the clinically significant bone disease is present by around the age of 5, and almost no clinically significant new bone disease will occur after the age of 5. At the age of 5, the disease will be there. It may not be bad yet, it can progress, but if it's not there by 5, the chances are that significant disease won't be there later. Okay, when do patients with fibrous dysplasia fracture? This gives you a sense of the pattern. Most of the fracturing is early on. There's some fracturing later. This is not terribly different than people who don't have fibrous dysplasia in terms of when the fractures occur. Kids fracture more often. They're more active. People grow up and get smarter, and they get less active as they get older. They fracture less. part of the point of this is that with fibrous dysplasia, there probably is more persistent fracturing into the later years. The fracture rate is highest in childhood, but it persists into adulthood. There's marked variability. Again, this depends on where the disease is, how much disease you have. Important modifiers of fracturing are endocrine disease. In particular, if you have low blood phosphorus, what we call renal phosphate wasting, that can really result in more fractures and earlier fractures. I did want to mention this, and I think that we don't really have a spine surgeon here, but probably Dr. Stanton will talk some about this. But I think this is really, really, really important. Untreated scoliosis is one of the very, very few aspects of fibrous dysplasia that can actually result in early death. And we've tragically seen this in some patients where scoliosis was developing and it was just allowed to get so bad that it was too late to operate. So I think it's really important that if you haven't been, that you're screened to see if there's fibrous dysplasia in the spine and if there's scoliosis. And if there is scoliosis, it really has to be tracked carefully. And Dr. Stanton can talk more about when those sorts of operations can take place. It was not appreciated that the spine was so commonly involved with fibrous dysplasia. And it's quite common. You can see, I don't know if you can really appreciate, but all these sort of dark areas in this woman's terribly curved spine are fibrous dysplasia. And what's amazing to me about this is that this woman was completely asymptomatic, although in terms of the spine. So you can have very commonly have involvement in the spine, but rarely is there any neurologic deficit. So rarely does it compress a nerve and cause nerve function loss, that sort of thing. And the other really surprising thing, and Dr. Stanton will talk about this as well, is that if you do catch this early, you do put these rods in, they amazingly work really well. Legs need operations every 2 or 3 years, but you know, spine surgeries last a long time. How long?
1978.
So 1978, one operation. Your other bones probably had 20 operations. So it's amazing. So bad news is you get it. The good news is if you catch it and fix it, it's stable. Okay, and these are a couple last things I'm going to show in the last minute. I think this is really important. So really, you know, the bottom line for all of us is what is the quality of our life? You know, how happy are we with the way we are? And this was a group of adults with fibrous dysplasia. In this outer circle in the yellow are the norms, and the inner circle, this line, this sort of radar plot, are adults with fibrous dysplasia. And if it's significantly different, it has a little asterisk. So we can see that in terms of physical function, as a group, patients, adults with fibrous dysplasia, do have some degree of compromise. And this depends on how much fibrous dysplasia you have. So if you're like Charlie and Geraldine in wheelchairs, you have some compromise in your quality of life due to physical function. And these other things, bodily pain, etc., general health. But in the really, really important parts of our life, the parts that make us who we are and decide how happy we are with life, vitality, social function, our emotional health, our mental health, adults with fibrous dysplasia are completely normal. They're no different than the normal population. So I think that's really important. When you look at children, it's the same thing. The degree of physical function results in some degree of compromise of happiness. And this goes around the same. But the one thing I wanted to pour out is really who is affected most is the parents. The parents literally suffer more than the kids. But the good news here, if you keep in mind, parents, that your kid is going to be fine, then perhaps there can be some relief of this. So this, I think, is really important. Things are going to be okay. And with that, I'm going to close. So I just wanted to acknowledge the people I've worked with, especially when I acknowledge Pam Noby. Pam was the one who started all these studies at the NIH in 1998, and she did this without a lot of help and cooperation. So she persisted and she pushed, and you know, a tremendous amount of information has come out of these studies that she started. We have wonderful nursing support, former fellows who have worked with us, and many collaborators throughout the NIH, including Jeff Kim, who is here today. And I did want to say one thing, that Penny Fouillon was one of the people who had been in NIH for many years and did a lot of early work in the precocious puberty, and she died tragically. And our dear friend Arabella Leach, who was a pediatric orthopedic surgeon, died tragically within the last year or two. And they were really wonderful people. We'll miss them. And this is where we work. This is where I work. Some of us work. This is the NIH. We work with the generous support of your tax dollars. So if you think it's worthwhile, you should let your elected officials know that this is important work and they should keep it up. And with that, I'm going to close, and I'm 3 minutes over. So we're going to move right on to Dr. Stanton.